Hello, my name is Scott Weiss, and I'm honored to talk with you today about the definitions, epidemiology, and pathophysiology of pediatric sepsis. So, here are my disclosures. I will mention some research that I was personally involved in, although I do not financially benefit personally from anything I'm going to discuss today. My objectives are to examine how the concept of sepsis as a definition and the diagnostic criteria have evolved over time, highlight key epidemiological trends worldwide for children with sepsis, and then review key pathophysiology underlying sepsis in children. Begin with definitions. So, although sepsis is commonly associated with modern emergent and intensive care, sepsis as a diagnosis has really been synonymous with Western medicine for several thousand years. Hippocrates in 400 BC is credited with coining the term sepsi or seppo, meaning I rot, which was consistent with the recognition of sepsis being the putrefaction of flesh. It wasn't really until the mid 1800s when Ignaz Semmelweis, a Austrian physician, recognized that women who were examined by medical students uh, soon after they, or immediately after the medical students left the anatomy dissection lab, were more likely to develop puerperal fever than women who were not examined by such students. And he made the connection that washing one's hands would potentially reduce the risk of developing sepsis in during childbirth. For this observation, he was actually laughed out of medicine because of the prevailing opinion that physicians are gentlemen and gentlemen have clean hands, and so there's no reason to wash them. He was actually committed to an insane asylum and somewhat ironically actually died of sepsis after receiving a cut on his hand. Soon thereafter, Louis Pasteur helped to more formalize the observations by Dr. Semmelweis when he proposed germ theory, recognizing that small microscopic organisms perhaps were responsible for causing illness and ultimately sepsis. And around the same time, George Lister, a German surgeon, recognized that if you sterilize instruments prior to surgery, that the risk of postoperative sepsis went down dramatically. Finally, almost 100 years later, David Asper and Tom Petty reported on acute respiratory distress syndrome in adults, making the connection that an infection in one area of the body could cause organ dysfunction, in their case, in the lungs, that was remote from the initial site of infection, and published this very important paper in the mid 1960s. And then Roger Bone, somewhat credited as the father of modern day sepsis in the late 1980s, really recognized that the overall host response was just as or equally important to the role of infection in causing systemic inflammation and organ dysfunction remote to the initial site of infection. And so ultimately, that led up to more of the modern day concept of sepsis that was first published in the early 1990s with this connection that sepsis is inherently a disorder of systemic inflammatory response syndrome that um, really at its fundamental core required systemic inflammation. And then those who had systemic inflammation with infection plus organ failure had severe sepsis. And if that organ failure was shock or cardiovascular dysfunction, then you had septic shock. This conceptualization of sepsis was revisited about 10 years later, and at the time, there was no evidence to support a change to the definitions. Around the same time, the definitions were slightly altered to fit the developmental criteria necessary for younger infants and children through the International Pediatric Sepsis Consensus Conference. That again required systemic inflammation through two or more SIRS criteria, with the addition of infection being sepsis, and then the addition of organ dysfunction, severe sepsis, and cardiovascular dysfunction as septic shock. Importantly, this conference highlighted the fact that in children, cardiovascular dysfunction was not necessarily defined by hypotension as it had been in adults, but rather by the presence of altered perfusion, in recognition that hypotension could be a late finding, particularly in infants and young children, a point that we'll reemphasize later in this talk. More recently, however, a large publication from Australia and New Zealand recognized that while systemic inflammatory response syndrome criteria were often present in patients who had infection plus organ failure who would otherwise be recognized as having sepsis, there were in fact many patients who did not meet SIRS criteria but still had infection plus organ failure and a fairly high mortality. And in fact, if you look over time, in patients who would be identified as having sepsis with or without SIRS criteria, there's really no difference per year in the risk of mortality if you had SIRS or not in this study. Although overall, the frequency of mortality was lower over time. This led to the more recent conceptualization of sepsis as no longer requiring a basis in systemic inflammatory response syndrome criteria, but rather codifying sepsis as what many clinicians really recognize sepsis to be, as a life-threatening organ dysfunction that was caused by a dysregulated host response to infection that may or may not require overt evidence of inflammation itself. This removed the term severe sepsis and replaced that term simply by the terminology of sepsis itself. And then those with septic shock were the subset who again had circulatory dysfunction as defined by the presence of hypotension despite needing vasoactive therapy, but also the presence of cellular and metabolic abnormalities, recognizing that shock is not just a circulatory phenomenon, but also a cellular and metabolic one. And this was operationalized as having a lactate greater than 2 millimoles per liter. At its core, however, differentiating sepsis from an uncomplicated infection is somewhat arbitrary. And in fact, sepsis lies somewhere in the pathway between uncomplicated infection and infection-related death. And along this pathway are evolving evidence of increasing inflammation with different degrees of organ dysfunction and shock as the presence of cardiovascular dysfunction. And the first sort of definitions of sepsis in the 90s and early 2000s drew the line here and said that if you didn't have SIRS criteria and solely had an infection, that was not sepsis. And if you had inflammation, that was sepsis. Whereas sepsis 3 and then severe sepsis and septic shock existed along this continuum. Whereas sepsis 3 moved this cut point to said, no, the dividing line between not having sepsis and having sepsis is the presence or absence of organ dysfunction. The problem, of course, is that patients still continue to present somewhere along this continuum. And when they have overt evidence of organ dysfunction or shock, it's very clear that we're treating sepsis or septic shock. But what about when the patients present earlier in this time frame? It becomes less clear about whether we're actually treating sepsis or perhaps preventing sepsis from occurring. And sometimes this can get a little bit tricky. I think importantly, from a clinical standpoint, one must differentiate between what it is to be defined with having sepsis and what it is to diagnose sepsis in clinical practice. And when you are defining sepsis, really you're focused on identifying a group of patients with a worse prognosis. And so that's really what the definitions papers that I mentioned earlier focused on. Whereas in clinical practice, the goal is to recognize early signs of severe infection that could evolve to sepsis. And so looking at criteria that are much earlier on becomes very important to enable early recognition and the initiation of treatment, even if the patient may or may not meet strict definitions of sepsis. Okay, shifting to epidemiology now, I think it is important to recognize that in general, sepsis, the treatment of sepsis is somewhat of a modern day success story in medicine, and that the overall risk of mortality has decreased dramatically over the last 50 to 80 years. And that's seen in overall sepsis as well as in comparison of the most common cause of sepsis in children, that is pneumonia, with the improvement in death attributable to other causes in children. Most of these benefits are attributable to public health initiatives such as vaccines and improvements in sanitation, as well as earlier recognition and the initiation of early and broad antibiotic therapy, availability of aggressive hemodynamic support, and then improved intensive and supportive care, especially over the last 30 to 40 years. However, sepsis continues to be a problem. This study from 2020 looked at cases of sepsis globally and estimated approximately 50 million cases of sepsis among all age groups in 2017, with about half of those cases being occurring in children who were less than 19 years of age, most of those in children less than 5 years of age. In terms of mortality, sepsis accounted for 11 million deaths in 2017. That's about 20% of all deaths worldwide. And in children, about 3.5 million deaths. So that's about a third of all sepsis mortality deaths worldwide occurred in children. Now, where these sepsis cases and risk of mortality occurs or is highest is not equally distributed throughout the world. And you can see from that same publication that most of the burden of sepsis remains in Latin and South America, Africa, and the Indian subcontinent, both for the highest incidence and highest mortality for sepsis among all age groups. From the Sprout study, which was a global point prevalence study of children with sepsis treated in a pediatric intensive care unit, it was recognized that about 8% of children at any one time are being treated for sepsis or septic shock in an ICU. And that point prevalence was a little bit lower in resource high areas, whereas in resource restricted areas, even in children who were treated in high volume pediatric ICU environments, mortality was higher in Asia, South America, and South Africa, or prevalence rather was higher. When we look at mortality among these patients, overall mortality was around 24%, but again differed geographically with slightly higher risk of mortality for children in, and again, low-resourced areas. And we see again the same trends from a meta-analysis that was published in JAMA Pediatrics in 2019 that looked at dozens of epidemiological studies from children with sepsis treated in different environments, both wards, EDs, and ICUs. And we can see the same downtrending percent of mortality. But if those studies that looked in developing countries in the orange, you can see that even as late as 2016, there continues to be a much higher risk of mortality than in studies that looked at developed countries. The epidemiology of infection is obviously paramount, as that is the inciting trigger for sepsis. And so most cases, in particular those severe cases, are often bacterial sepsis, but sepsis can be triggered by any infection, including viral, fungal, rickettsial, or parasitic infections. And you don't need a demonstrated infection or a confirmed infection to diagnose sepsis. You can have a clinical syndrome with a high probability of infection that should alert you to the likely presence of sepsis. And positive blood cultures, while helpful when they are available, only occur in about 30 to 60% of children with sepsis. And so we're often left to look for other sites or source of infection, or sometimes treat empirically when we can't get a pathologic diagnosis or a microbiologic diagnosis. In terms of the site of infection, globally, diarrheal illnesses are the most common cause of sepsis, followed by neonatal sepsis and then lower respiratory tract infections. When we look at US-based studies over time, in the graph on the bottom, we can see that respiratory infections, particularly pneumonia, remain the major driver of pediatric sepsis in developed nations. But we also see this dramatic rise in culture-negative sepsis without a specific source. And this may be somewhat attributable to improved recognition and maybe more liberal coding of the sepsis diagnoses, but also I think recognizes that sepsis is more frequently identified even when we can't ascertain a microbiologic diagnosis. In terms of when we can identify a microbiologic diagnosis, there's about an equal distribution between gram-positive and gram-negative bacterial infections, with gram-positive infections occurring slightly more commonly in resource-limited areas than gram-negative infections, whereas you see the opposite trend in more highly resourced areas, with Staph aureus being the most common gram-positive infections, followed by strep, and Pseudomonas klebsiella and E. coli being the most common gram-negative infections. Fungal infections, mostly in immunocompromised patients, and viral infections account for about 1 in 5 cases of sepsis, most often influenza, but more recently SARS-CoV-2. Organ dysfunction is the last sort of important piece that's required for a diagnosis of sepsis. And while there are published criteria to define organ dysfunction, these are somewhat onerous and difficult to remember. They also were made more for definitions of sepsis rather than clinical recognition. And so I think the important point here is that clinicians should look at these 6 organ systems, both from their clinical exam as well as their laboratory evaluations, to identify organ dysfunction in children with sepsis. Risk factors for mortality in children with sepsis include young age, less than 1 year, comorbid conditions such as cancer, prematurity, underlying neuromuscular disease, particularly static encephalopathy, and those with pre-existing heart disease. Children with hospital-acquired sepsis have about 4 to 5-fold higher risk of mortality, mostly because of underlying comorbid conditions compared to community-acquired sepsis. And then undernutrition and fluid overload also remain important risk factors. However, the most important risk factor for mortality is the number and severity of organ dysfunction. And we see this across a number of different studies. This is data from the Sprout study, which again showed the stepwise increase in risk of hospital mortality with accumulating number of organ dysfunctions. But every study that's been published has shown similar trends. And in fact, if we look at the risk of mortality amongst children with sepsis, we can see that in those who have multiple organ dysfunction syndrome, or MODS, defined as 2 or more organ dysfunctions, published mortality remains unacceptably high at around 20%. So 1 in 5 of these children succumb to their illness, whereas single organ dysfunction sepsis has a mortality that is much lower, less than 3 to 5%. And again, this is an epidemiological study done from the United States that showed that the overwhelming majority of children who die from sepsis do so with refractory shock and MODS. And when they die is important to recognize. So 4 studies, 2 from the UK and Australia, demonstrated that about half of children who die from sepsis do so within the first 24 to 48 hours of ICU admission, whereas in the US and North America, it's about a third of children die at this early stage. The remainder of deaths are spread out over the first week to several weeks and are mostly due to withdrawal of technological support or life-sustaining therapies when children fail to recover from a state of sustained organ dysfunction or sort of semi-chronic critical illness. Lastly, among those who survive, risk is not completely gone. And so it's been well described that amongst adults who survive sepsis, there's an increasing risk of mortality in the months and years following their septic episode. But we see a similar trend, although less robust data, in children with sepsis who continue to have an increased risk of mortality that outpaces children who do not develop sepsis, well beyond their hospital discharge. Moreover, even those who don't succumb to their septic illness, either at hospital discharge or beyond, often struggle with long-term morbidity. This study from the LAPS group, which was a study in the United States of children with vasoactive dependent septic shock, we can see that about a third of children failed to recover their baseline health-related quality of life by 12 months post-discharge. And in fact, 1 in 5 had really severe morbidity, even at 12 months post-discharge. So data from both the US and Europe demonstrates that about a third of children either die or have a deteriorated quality of life as a result of their septic illness. So sepsis-induced long-term morbidity remains a major problem, as does long-term mortality. Lastly, switching to an overview of pathophysiology for sepsis, which is extraordinarily complex and beyond the scope of this talk. But this diagram from Nelson's textbook in Pediatric highlights the key features of sepsis pathophysiology in children. And that begins with an infection that activates both the innate followed by the adaptive immune response, which triggers a series of pathogen associated and danger associated molecular patterns that cause a feed forward loop of ongoing inflammation, which includes complement activation, a transition to from a balance to a pro-coagulopathic microenvironment, and endotheliopathy that's marked by stickiness as well as leakiness of the endothelial vascular border. That results in microvascular shunt with tissue hypoxia, microthromboses from that endothelial activation and procoagulant environment, significant interstitial edema with capillary leak, leading to tissue hypoxia and dysoxia, which is exacerbated by inability to utilize oxygen to produce ATP at the mitochondrial level. All of those leading to multi-organ dysfunction syndrome and ultimately death. Again, this pathophysiology, the understanding of the pathophysiology of sepsis has evolved over time, beginning with this early 1990s conceptualization of sepsis as a primarily pro-inflammatory cytokine storm process, and then evolving to recognize that there's an ongoing compensatory anti-inflammatory response syndrome, or CARS, that initially was thought to occur after the initial inflammatory response, and now is recognized in many patients to occur simultaneously with the pro-inflammatory response that's superimposed on this genomic reprogramming that leads to fundamental alterations in the physiologic state of the host. This can evolve in patients who are unable to recover to a state of persistent inflammation and catabolism, where patients have this chronic critical illness that is this sort of second peak of mortality that I mentioned earlier. These patients who develop sepsis often look inflamed with evidence of fever, tachycardia, tachypnea, leukocytosis or leukopenia, and evidence of inflammation if you measure blood-based inflammatory proteins. They have alterations in perfusion, as indicated by alterations in mental status, decreased urine output, nasotemia, abnormalities in capillary refill, peripheral pulses, and extremity temperature, and then at later stages, evidence of lactic acidosis and hypotension. And then there's the presence of organ dysfunction, which can be seen both clinically, such as with hypoxemia, as well as on laboratory evaluation. Importantly, in adults who generally tend to present with high cardiac output and low SVR, sort of state of warm or distributive shock, pediatric sepsis is much more variable. And in fact, most children, particularly young children, infants, and preschool age children, are much more likely to present with low cardiac output and a high SVR state, so-called cold shock, which tends to have a higher risk of mortality than straight up distributive shock. And so the shock in pediatric shock is more complicated than just distributive shock, as there are elements of hypovolemia, and in particular in young children, cardiogenic shock with sepsis-induced myocardial dysfunction. Clinically, there's been efforts to distinguish between those children who have warm and cold shock with the clinical features you see listed here. And while this distinction is potentially helpful, I want to point out that the Surviving Sepsis campaign most recently warned against using bedside clinical signs in isolation to categorize septic shock in children as warm or cold, because it's often not clear based on things like extremity temperature, capillary refill, quality of pulses, pulse pressure, diastolic blood pressure, et cetera, whether the pathophysiology is truly one of myocardial dysfunction or vasoplegia. And so sometimes you can be fooled into thinking a patient does not have myocardial dysfunction if you don't look for it using other more other devices such as point-of-care ultrasound or echo or other direct measures of cardiac output. But it is important when you're treating sepsis to think of the balance between oxygen delivery and oxygen consumption. And this imbalance is really what defines shock. And so if we look at this diagram, graphing both oxygen consumption and delivery, we can see that as oxygen delivery falls in the early stages of shock, um, oxygen consumption remains stable, the so-called supply-independent oxygen consumption phase. And this occurs because the body is able to increase its extraction ratio of oxygen as indicated physiologically by a fall in central venous oxygen saturation. But that ability to do that is able to maintain oxygen consumption at the tissue level. Further decreases in oxygen delivery, however, will result in a fall in oxygen consumption at the tissue level, which will cause cellular injury, organ dysfunction, and ultimately death if not reversed. And this phase of shock is indicated by elevations in lactate. And so efforts to move the patient from the left side of this curve to the right are highly important in the early stages of septic shock resuscitation. As I indicated earlier, especially in infants and young children, as the patient progresses through their stages of shock, cardiac output is somewhat preserved um, as a result of um, compensatory mechanisms. And in particular, blood pressure is sustained even as cardiac output begins to fall due to a increase in systemic vascular resistance. And so one must be cognizant of this and recognize earlier signs of altered perfusion to diagnose septic shock in children rather than wait for the overt onset of hypotension, which may be a later finding. Finally, I'd like to conclude by mentioning that sepsis is a useful conceptualization, but actually probably represents many different subphenotypes. And so at the moment, we tend to think of sepsis and septic shock, as I mentioned earlier in this talk about how it's defined and conceptualized. And then we tend to apply a common set of management guidelines, such as the Surviving Sepsis campaign, with the expectation that's going to improve outcomes. And to some extent, there are common therapeutic interventions that do, in fact, improve outcomes. But at the heart of sepsis is really a multitude of different types of pathophysiological states. And so understanding that sub the subtypes of different pathophysiology is going to really be important to truly improve outcomes. And so work is ongoing in this field by many individuals. This is data from Joe Carcilla's group at University of Pittsburgh, where they recognize that different subphenotypes of children who have sepsis-associated MODS could be measured with a combination of routine and more sophisticated assays, but that these subphenotypes could lend themselves to different therapeutic options, such as immune stimulation for immune paralysis, plasma exchange for thrombocytopenia-associated multiple organ failure, and immune modulation for patients who had HLH and MAS overlap syndromes. So in conclusion, sepsis is an important clinical diagnosis, but one must recognize that oftentimes that diagnostic criteria can and should differ from the definition of sepsis, both of which have and will continue to evolve over time with scientific advances. Sepsis remains a common and deadly problem in children, with 1 in 10 children with sepsis-induced MODS succumbing to illness, even in resource-heavy environments. But health disparities dramatically drive adverse outcomes on a global scale. The pathophysiology of pediatric sepsis is inherently quite complex, but is increasingly being targeted for personalized and precision therapies, which I think will continue to evolve and advance over time. So thank you very much for your time. These are my, this is my email address, which will change after January 1st. I also refer you to the Children's Hospital of Philadelphia sepsis website for some additional information and resources. Thank you very much for your time.